personal friend, but he has been my mentor since last 15 years when we were associated together at Narayan. Thank you very much, sir, for giving me this opportunity. And I would also like to thank the BNA for having given me this opportunity to share my experience of managing brain aneurysms. I do not have any disclosures of conflict of interest. So, clipping or coiling neurosurgery versus neurointervention, this has been a contentious topic, a rather controversial one also, because we the neurosurgeons, we claim that clipping is the gold standard for treatment of aneurysms, because once we treat it and if done properly, almost 99% cure rate is there. Very rarely there is any recurrence with clipping, and whereas the neurointerventionist would claim that why do you have to open the skull for this procedure when we can just finish the procedure, coiling maybe within an hour or so, and the additional risk of secondary injuries due to retraction condition, due to the handling of the perforators, all this can be avoided by neurointervention. So over the last 15 years experience, initial part I was only an open surgeon doing only clipping, and over the last 8 years I have been doing a combination of clipping as well as neurointervention. So I would like to share my experience. For the sake of discussion, I have tried to classify these into clinical, radiological and socioeconomic factors. Age, I feel, is a very important factor, because if the patient is of a younger age and if we feel that the patient is amenable for clipping, I would rather advocate for clipping, because it is a durable option and it is permanent, and almost 99% there cannot be any recurrence if done properly. Comorbidities, if are there, if the patient is having, if it's not fit for a longer procedure, then of course neurointervention would be an ideal option. If there are renal dysfunctions, contrast hypersensitivity, nickel hypersensitivity, certain stents have retinols, so all those things, well, we might have, the neurointervention might have to take a back seat. In case of lobar hematomas, when there's a mass effect and we have to evacuate the hematoma, we as well go in and why not clip the aneurysm as well as take out the hematoma. This has been the conventional approach, but there is another thought process which is going on, which is also relevant. Why to expose the patient for, again, replete? So why not secure the aneurysm endovascularly and do a targeted craniotomy just to evacuate the hematoma? Similarly, for hydrocephalus, we can just do craniotomy and clip the aneurysm, open the lamina terminalis, give a good wash so that the subarachnoid blood can be taken care of. But on the other hand, after coiling, if it is a communicating hydrocephalus, serial lumbar punctures will help in draining this subarachnoid blood, and if it is a obstructive hydrocephalus, endoscopic ventriculostomy can be done. I would like to demonstrate one case in which we did that. Radiologically, of course, if in the age of elderly patients, it would be better to go for a neurointervention, but again the challenges are more sagging aortic arch, atherosclerotic changes, proximal artery occlusion, in which case we might have to place the angioplasty and stenting, and especially in the ruptured stentings where giving an antiplatelet might be a challenge. Wide neck aneurysms, of course, we might have to use a balloon, or sometimes neck devices might be needed, and in a ruptured stenting, placement of a stent might be a challenge. However, nowadays this is not, it's again a relative thing, because the newer IV antiplatelet agents like cangrelor, we can virtually place the stent and give the antiplatelet agent, so all these things are becoming less and less relevant. Coil compaction is an issue. If we place the coils and we need to follow up the patient, because there might be coil compaction, we might have to place additional coils and follow up, or we might have to place a stent or a flow diverter. And if there are perforators arising from the branches, then we could very well nicely do a reconstruction using the clips. Socioeconomic factors, at least in my practice, this has been a very sort of deciding factor in many of the cases, because affordability is an issue in our country. So because typically the neurointervention procedures cost almost 2 to 3 times that of the clipping. However, things are changing nowadays with a lot of hardware, catheters available in India, and a lot of these Chinese coils are available, which are almost 50% economical, and they're almost as effective as the regular ones. So things are slowly and steadily these are evening out. And of course, willingness for multiple sittings and good follow-up is necessary, because there could be coil compassion, there could be a recurrence, the patient should follow up, and if we feel that the follow-up and the willingness is an issue, then well, as we'll go in and do clipping. So, posterior circulation aneurysms, proximal ICA, cavernous, Para-ophthalmic aneurysms, personally I feel that it would be a less invasive and less morbid procedure to do an endovascular compared to the clipping. But as neurosurgeons, we need to keep our microsurgical skills sharpened, be ready, because still in many of the cases, surgical clipping is still the gold standard, where neurointervention, while we have to do lots of circus when just going in and placing a single clip would just solve the problem. So neurosurgery clipping is not a dying branch, it is a vibrant branch, and we need to keep it. As a neurosurgeon, especially for the younger ones, we have to keep it ready, and we should be virtually ready to clip any aneurysms. So I would like to share a few of my cases, initial clipping and then the coiling one. This was a patient who presented with WFNS grade 1 and Fisher grade 3 aneurysm. As you can see, this was almost like a giant aneurysm, almost a whitish neck. Endovascularly, maybe I could have treated this, maybe not, maybe. Now we have all these neck devices like Contour, in which you can easily place that and few coils. But this was a long time ago, this was almost 10 years ago, where I was just an open neurosurgeon then, and socioeconomic factors were an issue, so I decided to do a craniotomy. Two pieces of closure craniotomy was done, and then we did an extradural craniotomy, then wide opening of the Sylvian fissure, mobilizing the temporal pore, what we typically called half and half approach, approaching from the Sylvian fissure, trans-Sylvian as well as the subtemporal approach, exposing the tentorium, coagulating the free edge of the tentorium, cutting the tentorium to expose the aneurysm sac, and then proximally exposing the origin of the basilar trunk, and distally exposing the bifurcations into the bilateral SCAs, PCAs, third nerves and all, and then placing the temporary clip over the proximal basilar artery, and with very low power bipolar artery, around current of around 8 to 10, using a nice constant bipolar, I shunt the aneurysm fundus to make it more manageable, so that I could see the origin of the ipsilateral and contralateral PCAs and SCAs in the third nerves. And then after that, I placed a single ring clip encircling the ipsilateral PCA, and then an additional clip just distal to the origin of the PCA. And this was a fairly good result. Initially, the patient was a little stormy, but eventually in 3 weeks, patient could go home walking. When there are certain cases where there is a hematoma, this was a case in which the patient had bilateral MC aneurysm, so the right side was a bigger one, and there was a right temporal hematoma also, and there was very little SAH, and the patient GCS was not that good, around 7/15, so I had to go in. So, and this was an earlier case where I was just an open neurosurgeon, so I decided to go in. I did a craniotomy. I went from the right side, decompressed a little bit of the hematoma to make the brain lax, and then I went subfrontally to expose the proximal MCA, placed a temporary clip, and then secured the aneurysm on the right side, and then went in and evacuated the whole hematoma. And once the brain became lax, I could lift the frontal lobe on the ipsilateral and contralateral frontal lobes, and I could open the contralateral Sylvian fissure. I could go like this, and I could place a single clip, and as you can see, post-operatively, the patient had a dramatic improvement, because basically the degradation was because of the hematoma, and almost by post-op day 4 or 5, patient became GCS 15, and this was a good outcome. Then ACOM aneurysm, this was a routine A1 junction aneurysm, Fisher grade 3, WFNS grade 1. As you can see, pretty narrow neck, straightforward case. We placed a single clip and opened the lamina terminalis, and patient had a good outcome. Most of the cases which we get, at least in my practice, have been the ruptured ones. This was an incidentally detected aneurysm. Someone did a CT angio, they found an aneurysm, and they referred to us. And this was a case like a P2 aneurysm. As you can see, the vessel wall itself is diseased. Although this is a saccular aneurysm, the vessel wall itself is a little bit diseased. I would be able to, if I get this patient now, then maybe I would offer a simple flow diverter, and that will just solve the problem. But these were early days, so I decided to do craniotomy and clipping. This was a left lateral position, an inverted L-shaped incision. As you can see, the anterior subtemporal approach I used, retracted the temporal lobe, and subpyral dissection of a little bit of uncus to expose the aneurysm fundus. I traced the long perforator proximally to the origin of the PCA, and then exposed the proximal and distal PCAs, placed a temporary clip over the proximal P2 PCA, and then placed initially a single clip and then a reinforcing second clip and this was the result. There was no residual aneurysm. There was a fairly good result, but since, as you can see, the vessel was diseased, and I have been following up the patient for the last 3 to 4 years. There is no recurrence, and if there is a recurrence, maybe we will place a flow diverter. So this was the thing. Then neurointervention cases, sometimes we have to resort to this thing. This was a patient with a mirror aneurysm, bilateral displaced ophthalmic segments, a giant right ophthalmic aneurysm and a smaller left side aneurysm, incidentally detected for headache. Routine antiplatelet regimen. What I do is for flow diverters, I use tecagrelor and ecosprin because clopidogrel resistance is an entity and we do not want to take the risk of thrombosis of the stent. So what we do, a routine DSA, and this was, as you can see, a fusiform aneurysm with a saccular outpouching. Routine procedure for placement of FD. This was we placed a pipeline flex with shield. So straightforward procedure, went in and placed a flow diverter. And this is the CT angio after placing the FD. The patient had a left-sided So as you can see, the left-sided also patient had an ophthalmic aneurysm, and this I have been following up for the last 1 year. This is immediate post-op. As you can see, a dramatic result pre-op, immediate post-op, and at 4 months, there's a tiny aneurysm, and this at almost 8 months, I had got a liquid CT angio, it had fully disappeared, and the left side one remains the same, and we'll be observing the patient annually, and if it increases, then maybe we'll place an FD on the opposite side also. Then ruptured distal basilar aneurysm. This was again WFNS grade 1, fissure grade 3. Patient had a SCA-PCA junction, neck aneurysm, and there was an incidental tiny A1 aneurysm also. What we did was routine procedure, placed 2-3 coils, and we had to save this SCA origin, so maybe we will have to observe this. There could be some coil compaction. Couple of years follow-up, there has not been any compaction, so in that case, we are just observing this patient. This was before and after. MCA bifurcation, typically clipping is the one which is sought after, but we can even do coiling also. This was again an SAH with WFNS grade 1. This was a narrow neck aneurysm. What we did, but what I did was in this, we had to use a triaxial system, use an intermediate catheter also. This was the pre-calling, and this was the post-calling, and the post-operatively patient was fine. Not every time the case is straightforward. Access might be sometimes difficult, especially in the elderly patient. If there is a type 3 arch, or if it's a truncus, if there are atherosclerotic changes which are not allowing us to access the carotid system, in that case, we might have to directly go from the neck. Ideally, this would be the approach. What I do is, if we can even use an ultrasonic guided puncture, or we could just go, as in neurosurgeons, we routinely do ACDF, we expose that area, so we could just expose with the transverse skin crease incision and directly under vision place a radial sheath, and then rest of the procedure is straightforward. These are the pre-calling images, this is post-calling, skin crease scar, and over 6 to 8 months it will virtually disappear. So procedure was straightforward, post-procedure calling was done. This is another case. As you can see, there was atherosclerotic change. I did not want to mess up with this, so what I decided, directly a neck exposure and then IC bifurcation aneurysm. That procedure was again straightforward. Ruptured ecom aneurysm, a wideish neck. I had to use a balloon for that, and then place 3-4 coils, and that's it. Chinese coils, I told the left 2 coils which are there, these are pretty good. This is a case where there was a PCA ecom junction aneurysm. This is a coil mass and a fairly good result. The routine cases, IC bifurcation, is ecom aneurysm, MC, and all. I would like to end by discussing one case which was an eventful and challenging case. Eventful not because of the neurointervention procedure as said, because it was a straightforward one. As you can see, the CT angio and pre-calling runs, narrow neck one, straightforward SCA PCA junction aneurysm, post-coiling, 2-3 coils are placed, and everything went well. It was an uneventful procedure. Only thing was that the vertical was quite tortuous, and there were 180-degree turns, and I could not, the intermediate catheter, I could not negotiate beyond the first curve. So I had to place it at the first curve, and then I had to place the catheter. Other than that, I felt I did a fantastic job, but post CT scan, massive SAH and IVH also, and hydrocephalus. So I had to do an endoscopic third ventriculostomy. This is the foramen of Monroe. As you can see, preponderant space, lot of SAH, and post that chest X-ray showed a left lung complete atelectasis. She was a bronchial asthmatic, maybe one of the bullae would have ruptured, I don't know. So, and she had severe delayed cerebral ischemia, vasospasm. We had to treat with intense Nicolex therapy, noradrenaline for almost 3 weeks. Whenever we taper the norid, she used to deteriorate. So we had to virtually chase that, and we had to do drainage LPs because we had converted obstructive hydrocephalus into a communicating hydrocephalus. Initial LPs, the CSF was thick like blood, and over the fourth or fifth LP it became clear, and we had to do a tracheostomy and intensive physiotherapy. But at the end of 2 months, we could remove the Rice tube, remove the Foley's catheter, close the tracheostomy, and the patient went home walking. This is the patient smiling. So the moral of the story: never give up, keep trying. We don't know what will work in our favor. So again, to summarize, clinical, radiological and socioeconomic factors will guide us, and with faster evolving and refined hardware, better training and skills, virtually any aneurysm can be treated endovascularly. But as clinicians, we need to have a balanced approach and involve decision making with the prime focus of patients' well-being as the guiding force, and of course with an active and informed participation of the patients and their representatives, because both of them have their pros and cons, and definitely we need to have you weightage to each of them as per their merits. I'd like to thank my mentors, Professor Oishi. This is he's the head of department at Children's University Tokyo, who was my teacher and mentor. And this is Professor Hirotoshi Sano, also called as White Jack because he holds the world record for the largest number of aneurysms clipped. And this was at Showa University where I got to participate in the cerebrovascular bypass. And finally, I would like to end my talk by offering my salutations to my mentors, Karapoka sir, Ranjit Singh sir, and Professor Oishi. These are the giants on whose shoulders we are standing today, and because of their pearls and their guidance, today I have got the courage to stand in front of you and share my humble presentation. Thank you very much. Thank you.